Dear students, this is Terez Boshra Kamel talking to you in the last part of tuberculosis lecture about how to diagnose and suspect tuberculosis in children and how to treat. So, to diagnose tuberculosis, we have a flow chart. Please follow with me. If a child coughing for 2 weeks or even more and not responding, these respiratory symptoms, not responding to the regular antibiotics, we have to have for him 2 sputum smears, 2 successive sputum smears, okay? And I will do for him Zell-Nielsen stain. If 1 or 2 is positive, it's called sputum positive pulmonary tuberculosis, and I will start anti-tuberculous treatment, okay? What about if having 2 negative, which is the common case in children because they are bacillary, so they have sputum negative? I will give regular adequate dose of antibiotics for 10 to 14 days. Or what about if the cough persists, so it is called cough resistant to antibiotics? Again, I will suspect tuberculosis. I will repeat 2 successive sputum examination. If 1 or 2 is positive, I will give anti-tuberculous. If it's still negative, which is the case in children, I will perform for him X-ray chest. If it is suggestive of tuberculosis, I will tell that it is sputum negative pulmonary tuberculosis and I will start anti-tuberculous treatment. If it is negative for tuberculosis suggestion, it is not the site or no evidence of pulmonary infection, lymphadenitis or something, it is not TB, and I will follow him and investigate for other disease. What is the rule? Also, there is a rule for tuberculin test, which I will mention later, okay? So, I will start taking adequate medical history. Tuberculosis should be suspected when a persistent respiratory illness in an otherwise healthy individual does not respond to regular antibiotics. This is the pearl for tuberculosis to be diagnosed. What about these respiratory symptoms? The commonest are prolonged cough, an unremitting cough that is not improving and has been present for more than 21 days, more than 3 weeks he is coughing, with fever reaching more than 38% for 14 days after common causes such as malaria, pneumonia, UTI, otitis media have been excluded. The child have got weight loss and failure to thrive. So I must consider to have the following lab diagnosis to add to my diagnosis. I will have for him chest X-ray. I will have tuberculin test, which is very important. I will have some blood tests, microscopic examination as we mentioned before for the sputum, and microbiological culture of the fluid affected. Sputum if it is pulmonary, CSF if I'm suspecting CNS, okay, peritoneal fluid if he has got peritoneal tuberculosis. And some scientists developed what's called scoring system. If he has negative for all investigation, I will have him scoring system based on clinical data, because children are bacillary. I cannot detect for them Zell-Nielsen or giving a positive culture. Contacts also screened for tuberculosis and treated if necessary. Chest X-ray can be like that in a child with respiratory symptom not responding to regular antibiotics for more than 3 weeks. Suspect tuberculosis. It can be any form in the radiological finding. Can be patchy pneumonia like that. Can be pleural effusion like that. Can have lower lobe pneumonia. Can have just lymphadenitis inside here. Okay. I will confirm by having CT chest. I can have this abscess formation, as we see here. It is not apparent just X-ray. Such bronchiectasis or something like fluid, air fluid level in such X-ray picture. What about tuberculin skin test? It is an important screening test for tuberculosis. It is called Manteau tuberculin test. It is an intradermal injection. Intradermal. We will inject 0.1 milli containing 5 tuberculin units of purified protein derivatives called BBD. In duration, in response to the test, should be measured by a trained person 48 to 72 hours after administration of the BBD particles. For who I will investigate for tuberculin test? Contacts of people with confirmed or suspected tuberculosis. Children with radiographic and clinical findings suggesting tuberculosis disease. Children immigrating from countries with endemic infection. Children who travel with travel history to countries with endemic infection and substantial contact with people from such countries. Remember that false negative tuberculin test can occur in very young age if the child is malnourished, if he is immunosuppressed, if he has got vaccination with live virus vaccine, commonly MMR, okay? If MMR can cause false negative tuberculin test. Overwhelming tuberculosis can cause allergy and a state of immunosuppression, so I will have false negative tuberculin test. I have tuberculosis disease, but I have negative tuberculin test. That's called false negative. The most common reason for a false negative skin test are poor technique and misreading of the results. False positive reaction to tuberculin, which means I don't have tuberculosis, but I have positive reactive tuberculin test occurs when there is cross-sensitization to antigen of non-tuberculous mycobacterium. Remember which one? Yes, Mycobacterium avium complex. Or if I have previous vaccination of BCG vaccine can cause false positive reaction to tuberculin test, which is common in our country. We are taking BCG vaccine routinely in our vaccination program. How to do tuberculin test? Remember, it is intradermal test. Intradermal, injecting the BBD particles intradermally, and I will wait for 48 to 72 hours, okay? And I will measure the induration, not the redness, the induration. So positive tuberculin test, it is considered when there is induration, not redness, more than 1 centimeter in diameter, 10 millimeter in diameter. How to interpret tuberculin test? If tuberculin test is positive, I will revise the chest X-ray. If it is normal and the patient has no symptoms, it is latent TB infection. Okay? If it is abnormal X-ray, I will revise his Zell-Nelson and sputum culture. If positive for TB, I will consider anti-tuberculous treatment. If negative, I will consider latent TB infection, especially if he has no symptoms. Okay? And I will revise his X-ray later. If the negative tuberculin test from the start, I will ask the patient if he has got prior negative tuberculin test within the 12 months before. Okay? If the answer is yes, so no further action. If the answer is no, I will repeat his tuberculin test after 3 weeks later. If positive result, I will follow up the previous chart, X-ray, sputum culture and sensitivity, and consider the result. What about new techniques for diagnosis? It is called interferon gamma release assay, or IGRA. IGRAs are based on the ability of Mycobacterium tuberculosis antigens for early secretory antigens targeting what's called target 6 or East 6 to stimulate host production of interferon gamma. Means I have the immunity against special antigens of Mycobacterium tuberculosis. Because these antigens are not present in non-tuberculous Mycobacterium in avium complex or in BCG vaccination variants, so I can have positive IGRA test, which is the diagnostic for latent TB infection not due to previous vaccination, so can be important in pseudo positive or false positive cases. What about anti-tuberculous drugs? They are special categories of drugs. Must be used only if I am suspecting tuberculosis. We cannot use these drugs in another infection, otherwise resistance to these drugs can occur, which can cause multi-drug resistant TB, and we cannot control TB anymore. We have the first group, which is the first choice, which are rifampicin, INH, which is isoniazide, pyrazinamide, and isambutol. They have got doses, which is called daily doses or twice per week dose or dot technique for therapy, and I will mention to you later. What about multi-drug resistant tuberculosis? It is from its name, it is multi-drug. It means there is infection by organism which cannot be treated by the regular first group of anti-tuberculous therapies, especially INH and rifampicin. Can be primary resistance to anti-tuberculous treatment in an individual who has no history of prior treatment. So he is from the start infected with mycobacteria that is resistant to drugs. While second resistance, it is the emergence of resistance during the course of inefficient anti-tuberculosis therapy. The patient is not getting his regular dose or regular management, or he is missing doses for anti-tuberculosis therapy. So he can develop secondary resistance. If that occurs, what we will do, we will mention for him and prescribe for him second line medication, which is mostly injections, rarely oral. Amikacin, capreomycin, cycloserine, cyanoamide, streptomycin, aminosalicylic acid, fluoroquinolones, which are not regular for use in children. What about the recommended pediatric tuberculosis treatment regimen? For how long we will give the child the treatment? We'll give him 6 months course. The first 2 months will be INH, rifampicin, pyrazinamide together supplemented during the first 2 months. Then the other 4 months will continue as INH, rifampicin. What about extra-pulmonary tuberculosis in children? Treated with the same regimen as pulmonary disease. Exception are that disseminated tuberculosis and tuberculous meningitis will give up to 12 months of treatment, completely 1 year. What about DOTS therapy, which is direct observation therapy with short course of anti-tuberculous treatment? From its name, it is directly observed for us to see the patient taking the medication. Direct observation of therapy involves providing the anti-tuberculous drugs directly to the patient and watching the patient swallows the medication. It is the preferred core management strategy for all patients with tuberculosis. Why? To prevent secondary multi-drug resistance. You remember? What about other drugs used in treatment? We have to use steroids in special situations. If we have TB meningitis, if we have TB pericarditis, if we have miliary tuberculosis, and we will discuss together this case. A 10-year-old boy visits the health department for a tuberculin skin test because he is required to have one before traveling to US with his family. He has an 18mm positive reaction to the tuberculin test. He has no symptoms of TB. His chest X-ray findings are normal. So, please highlight the data and red flags. Should this be considered a case of TB? Of course not. The boy described above has TB infection, latent TB infection. He has an 18 positive reaction to tuberculin test, but no evidence of TB disease Therefore, this is not a case of tuberculosis. Should he be considered infectious to others? No, he should not be considered infectious to others. He has latent TB infection, not TB disease. So, must he receive treatment? Remember, yes, he must receive treatment for short course. Yes, because he can turn in 10% to up to 40. He's not an infant, so in 10% he can turn to tuberculous disease. So again, this is the case, a reactive tuberculin test, okay, more than 10, with absence of clinical and radiological manifestation. This is latent TB infection. If positive tuberculin test with chest X-ray positive and respiratory symptoms more than 2 weeks or even 3 weeks not responding to antibiotics, it is an active, please consider active tuberculosis. What are the risk factors for progression of latent TB infection to tuberculosis disease? Remember, if the child less than 4 years of age and adolescents, persons co-infected with HIV, persons who are immune compromised with malignancy, solid organ transplantation, immunosuppressive medical treatments. How to prevent tuberculosis? We have 2 steps. Finding infected cases and adequately treat them. This is TB control programs. We have an efficient one in Egypt. Bacillus Calmette-Guérin vaccination. It cannot prevent TB but prevent complications, especially TB meningitis. Please remember that. Cannot prevent TB, it prevents complication. So, Bacille Calmette-Guérin vaccination, BCG vaccination. It is attenuated strain of Mycobacterium bovis, given intradermal injection at the insertion of the deltoid, as we see in the picture. Safe in immunocompetent hosts, can cause local ulceration and regional suppuration, adenitis in up to 1% of the recipients of BCG vaccine. Please ready with your question in the next face-to-face session.